All right, it is 1:30. Let's get started. All right, welcome everyone to our session. This is Youth at the Crossroad of Substance Use, Healthcare, and Homelessness. First, I would like to acknowledge and welcome you all here to meet on the territory of the Mi'kmaq, the ancestral home of the Mi'kmaq peoples. Thank you so much for being with us today. Our first presentation is going to be addressing youth homelessness and recovery through a harm reduction lens. And so I'm happy to introduce Casey and Angela. Casey has worked in many youth supporting roles over the last 15 years with Child and Family Services and is now the manager of Threshold's Supportive Recovery Program. She's a fierce advocate for social justice and is passionate about harm reduction services for youth. And then Angela has worked in the housing sector for over 30 years with a specialization in supportive housing and outreach programs for youth and adults. She's a fierce advocate with social justice, human rights, and equity as a primary focus in decision making. She believes in building strong teams and working diligently to foster an environment of taking care of those who take care of the people we support. And so I will welcome them up. And thank you.
Yeah.
All right. So welcome.
Awesome. Thank you.
Everyone.
Hello. My name is Casey Sturrett.
And I'm Angela McNulty-Buell, as you just heard. We will be reading off of our little tablet here, so we are going to be looking down but looking up. And we're here with the amazing Threshold Housing Society from the beautiful Victoria, British Columbia. As was said, Casey's the manager of our Supportive Recovery Program, and I'm the director of Housing and Support Services. We want to start by saying, as a youth-serving organization, we recognize the historic land displacement experienced by Indigenous youth and families and the disproportionate representation seen in unhoused communities, and that we have a responsibility to provide culturally safe housing to youth residing on the traditional territory of the Esquimalt, Songhees, and Wasanic people, lands where we do our work. We also want to thank and acknowledge the Mi'kmaq people whose lands we are gathering on today.
So Threshold Housing Society's mission is to prevent adult homelessness by providing safe housing, support services, and community to at-risk youth, and envisions a community where all youth thrive. We've been providing housing and supports to at-risk youth aged 15 to 24 in Greater Victoria for the past 32 years. Our mandate is to house vulnerable youth who are experiencing homelessness or at risk of homelessness, and to augment the experience of being safely housed with innovative programming, individualized case management, and increasing connections to community-based resources.
As an organization, we have demonstrated experience in achieving successful outcomes for a variety of youth in housing models. The current infrastructure allows us to create a flow of housing options based on the level of support a youth requires at any given time, and the ability to move youth through a housing and support continuum based on their level of support needs as it increases and decreases.
Okay, so this is why you're really all here.
This is what you want.
This is my love. So youth recovery is vastly under-discussed in our sector. No one wants to talk about youth using drugs, and in reality, much of it goes unseen. The unfortunate reality is that youth are using drugs in riskier situations, in higher quantities, and are dying at more alarming rates than ever before. At present moment, many of the services for youth operate from an abstinence-only model, which is beneficial in the right context, but it's not always the right service at the right time. Recovery defined by complete abstinence does not align with every youth's goals. Recovery is a subjective experience, and having a collective definition leaves out opportunities for connection and healing.
Amazing. Yoo-hoo! At Threshold, we strongly advocate for the agency and autonomy of each youth. While our program is a recovery program, we allow the youth to determine what recovery means to them.
It's important to note that youth cannot be mandated to our program, and that all youth in the program have identified that recovery is a goal for them. For some youth, they are working towards total abstinence, but are not quite ready for that. For others, recovery means learning to use substances safely. What is important is learning the skills and having opportunities to practice those skills in real life situations.
And we define harm reduction as keeping youth safe in ways that work best for them, as Casey just said, and we accept that youth substance use is happening, whether we're comfortable with it or not. It's a live reality, and we aim to provide a non-judgmental, trauma-informed, and person-centered focus to all the supports and services that we offer. Are we still there? The secret sauce. After years of recognizing the correlation between youth who experience substance use and those, wait a minute.
Here.
I've lost my place.
Right here.
Oh yeah, after years of recognizing the correlation between youth who experience, here we are. This is the problem. Ha-ha! I was wondering, I'm like, I can't see what's happening. Here we are. So, after years of recognizing the correlation between youth who experience substance use challenges and those who experience being homeless, implementation of our residential recovery program that employs harm reduction and housing first principles felt critical. 40% of the youth applying to our programs indicate that they are currently homeless, and youth who experience a substance use disorder are at a higher rate of experiencing chronic long-term homelessness. As well, they are experiencing fatal overdoses at a higher rate than ever before. When Casey and I were working on this presentation last night, we got a live alert that in British Columbia right now, in Victoria more specifically in our community, there is an alert that there is the most toxic drugs that have been on our street to date right now, currently as we're doing this presentation. So we're kind of scared. We're scared to return home and see who might not be there waiting for us. By meeting youth where they are at, we are supporting them in a more holistic way to engage with their substance use and gain valuable recovery and life skills while having autonomy.
Okay, so we'd like to offer some tangible skills. That was the requirement. So we call our tangible skills the secret sauce. These are things that other organizations like You Find Folks can use to implement in your programs. Talking about youth harm reduction in the context of youth work is scary, but over the last 2.5 years, we have found a sweet spot of things that are working, and the outcomes that we are seeing are really incredible. Prepare to be sick of my voice. There are common barriers that folks face prior to entering our program, such as accessing detox, where they are asked to discontinue taking safe supply or stop utilizing cannabis and tobacco products. I think we can all agree that no one is going to detox to address their cigarettes or their cannabis use. While our program does require a period of stability, we have a significant amount of flexibility in that requirement, and we'll meet youth where they're at. If accessing those medicinal programs isn't the right fit for them, we will meet them in community and support them in detoxing safely before they come into our recovery home. We also encourage youth to connect with their primary care team to access pharmaceuticals like Safe Supply, because Safe Supply saves lives. Our program encourages youth to find what works for them, and at no time will we ever ask a youth to discontinue their medications that support their recovery journey. I cannot emphasize it enough that we do not subscribe to the idea that recovery equals abstinence. Recovery is defined by individual youth and their individual experience. At SRP, we support youth in using tobacco and cannabis as a harm reduction strategy. Yes, even the ones that are 15. While at face value, this may seem like we are supporting further use of substances, we are actually just trying to build awareness around their substance use. We use these substances as an opportunity to have those conversations, to build those connections. All substances, whether they're legal or illicit, are kept in the staff office so that there's a built-in opportunity for us to say, what's going on for you right now? Where are you feeling this in your body, and what are you hoping to achieve? Are there other coping strategies I can offer you, or is there something that we can do after to support you? We have found that this allows youth to be intentional about their substance use and be aware of how substances actually affect them. We are finding that youth who come into our program who don't want to look at their cannabis use or have identified cannabis as being one of their main tools are actually becoming more intentional when they leave the program. We recently had a youth come into our program who was smoking cannabis upwards of 15 to 20 times a day. And after leaving our program, they left with an arsenal of alternative coping strategies, including being able to just label their feelings and talk about where they're at. And they had reduced their use to 3 or 4 times a day. It's really, really incredible. And that is not just like a single statistic. That is something we are seeing consistently over and over. Our entire program is created to build up a youth's toolkits of coping strategies. Each week has a recovery theme. For example, this week is emotional regulation. I'm sure we could all use that sometimes. Our staff work with the youth throughout the week to practice the new skills that we're teaching them about. We offer a robust activity calendar, and while on paper it looks like, oh, these are new coping strategies that they can use, it is also just an opportunity for these kids to be kids. These kids are coming from unhoused situations. They haven't got to be kids. And so we are doing things that maybe you would do in a kindergarten class, and it is a hoot. Youth identify what resources might be useful to them, such as their primary care, mental health, counseling, or accessing groups like NA or AA. Our program recognizes that all youth have different learning styles, and that's, I think, something to keep in mind, whether you work with youth or adult populations, is that people learn differently. Some may thrive in those group settings, and that's awesome. I don't. I don't love a group setting. I get nervous. But I do love those one-to-one connections. I love those nonverbal forms of communication. I think that often in youth work, we forget that, like, youth don't talk, they text. And, like, leaning on those techie supports is, like, a huge opportunity for connection. And it allows staff to practice those coping strategies and those new skills in the real world. In recovery-based programs, a youth who experiences a slip or is using cannabis is often discharged from the program. A really unique part of our program is that we believe that during, after, before, at all times, a slip is like one of the best opportunities to provide support and connection. We attempt to create a space where youth feel comfortable talking about their substance use, and we really focus on undoing that shame and stigma. We're not going to be here forever, but you're practicing those skills of talking about your substance use, and maybe when you leave us, you will tell somebody else that you're planning to use. You'll tell somebody else that you're having cravings. If a youth comes to us and says, listen, I've used all my coping skills, I'm going to go out and I'm going to use, we'll obviously try and engage them in other coping strategies. Our ultimate goal is to keep kids alive. You will hear me say it again, dead kids don't recover. It is our responsibility to ensure that we are providing them opportunities to stay alive. We recognize that cravings are normal. There's no shame in that game. We all have it. And being able to talk about your cravings when you have them is an opportunity for intervention and learning. Ultimately, we subscribe to the trans-theoretical model of change and believe that relapse is a part of recovery. It is not a bad thing. If a youth comes to me and says, you know, I'm going out to use, I say, cool, let's make a plan. I will take that youth to go pick up substances, get them tested, and I will bring them to wherever they want to use. I will supervise their youth to make sure that they're safe. I will bring them back to my resource, and I will provide the highest level of care and love that I can. There is no shame in substance use. Shame is what is killing our kids. So, the opposite of addiction is connection. And after a relapse, that's when someone needs the most connection. The number one thing that I think all of us can do to support our young folks or other people who use substances is to create space for conversations about drug use to happen. It's happening. We can't put our head in the sand. Problematic substance use thrives in secrecy. In many spaces, youth feel that they need to hide their substance use from their parents, teachers, and supports. When we have conversations that say, hey, what you're doing is okay, I care about you, and I just want you to be safe. There are more opportunities to normalize that substance use, reduce the shame and stigma, and provide skills that can keep folks alive. The more comfortable we get with drug use, the more honest our youth will be able to be.
How do I follow that? Woo! So youth substance use and homelessness, we know they're related. We know they're interconnected. There's no denying it. And we know that there are some common and general trends that support this. Youth who use substances are more vulnerable to, as I said earlier, chronic homelessness due to issues like addiction, unstable relationships, family disconnection, and financial instability. Substance use often co-occurs with other risk factors for homelessness, such as family conflict, mental wellness concerns, and a lack of social support. With these trends in mind, it's important to focus on prevention and diversion strategies to at-risk youth before they become homeless. Providing access to the recovery continuum, mental health services, and stable housing options will mitigate the risk and disrupt the trajectory into adult homelessness. We know this with clarity. We know this. We believe emphatically that youth harm reduction focused programs, such as our supportive recovery program, directly disrupt the pathway to adult homelessness. Walking alongside the youth we serve with compassion and grace, and most importantly, hope, allows them to contemplate and ultimately experience a life where connection and belonging feels possible. As a former participant in our program recently stated to us during a follow-up meeting, I'm 520 days sober, I have a home, I live with my girlfriend, and we have a cat. And there's the cat. There really isn't anything that makes us more motivated and sharply focused than comments, stories, and realities like the one I just shared. It's powerful.
While we've had many successes, there have been challenges, and this is uncharted territory. And it can be scary to know what the right thing to do is. But that being said, the youth in the program have been incredibly successful. Overall, our biggest takeaway for today is that harm reduction works and that it should be available to youth if they want it. Keeping folks alive is the first and foremost priority. And again, dead kids don't recover. Housing shouldn't be contingent on a youth's sobriety, and without housing, recovery isn't possible. It has been 2 years of constant learning and creativity, but we've never been so proud to be a part of something. Thank you.
Thanks very much.
Thank you so much for that. Dead kids don't recover. We are always so reluctant to do harm reduction and safe supply with youth because we feel uncomfortable about it and we really need to get over ourselves. Yeah, thank you so much for that presentation. Our next presentation, I'm going to welcome Alzara. She's going to talk about Where's the Disconnect? Exploring Pathways to Healthcare Coordinated for Youth Experiencing Homelessness in Toronto, Canada. She is a PhD candidate in the Population Health Program at the Interdisciplinary School of Health Sciences at the University of Ottawa. She holds a Master's in Public Health from Queen's and a Bachelor of Science from McMaster. Her research focuses on systems thinking in the youth homelessness sector. She has dedicated her work to date on conducting research that is focused on a future where people have equitable access to health care, especially for those who face systemic oppression around the world. Over the years, she has conducted health research internationally on topics including maternal and child health, domestic violence, and substance use among street youth.
have to. All right, thank you for that lovely introduction, and I just want to say that was an incredible presentation. So good afternoon, everyone. My name's Elzara, and today I'll be discussing young people's pathways to healthcare, specifically those who reside within emergency youth shelters in Toronto. So I'll first start by providing some background before delving into my methodology and some of the findings that resulted from my dissertation, before engaging in some discussion and then finally some conclusions. So the purpose of my presentation is threefold. It's to understand pathways to healthcare for youth experiencing homelessness who reside at emergency youth shelters. It's to understand what variables or inputs influence those pathways to healthcare, and then finally to discuss recommendations, which I term levers for change. It's a technical systems thinking term, but you'll see it, and that's what I'm talking about. They're just recommendations and interventions in terms of how healthcare coordination can be strengthened both within the shelter system and health system, but also between the shelter system and the health system. So first, some background. It's no surprise that the youth shelter system and health system, as well as various other public systems, operate in silos. I think there have been some efforts to collaborate through Ontario health teams, various community hospital collaborations, although those are often in the form of studies or pilot projects. We know that youth often fall through the cracks of these public systems, especially when they're transitioning between systems or experiencing crises. We know, and I think this has also been very, very evident over the last few years, but we know the shelter system and health systems are over capacity, they're overburdened, especially since the pandemic. And the last three came up quite a bit in my research, but we know that young people are often prematurely discharged from hospitals. We know that there aren't any healthcare coordination processes that are consistent within each of these systems or between these systems, and therefore there is an urgent need for healthcare coordination and systems integration. So just so that we're all on the same page, I've pulled up a definition for healthcare coordination that resonated most with me, and it's the deliberate organization of patient care activities between two or more participants, of which one includes the patient. They need to be fully involved in their healthcare plan in order to facilitate the appropriate delivery of healthcare services. And of course, this would ideally include cross-sector collaboration to serve the complex needs of youth experiencing homelessness. So my research question was, how do the emergency youth shelter system and health system engage or collaborate to coordinate healthcare for youth experiencing homelessness in Toronto? And I approached my research using a systems thinking and organizational change lens. So everything you see is informed by this specific framework, where I look at the fundamental system parts of each of these systems that can act as potential root causes for poor healthcare coordination, how these different parts work together, and then finally what some levers for change are, so parts that can be targeted to strengthen healthcare coordination within and between systems. I'll just quickly go through the methodology. So this was a purely qualitative case study. I recruited stakeholders from both sectors. So this included high-level executives from within the youth shelter and health system, frontline staff who had both clinical and non-clinical backgrounds, and then, of course, youth experiencing homelessness who had first-hand experience navigating and receiving care from within either of these systems. And then all of this data was analyzed using grounded theory, it's a methodology where you're constantly comparing data as it's been collected and analyzed, and throughout the process, you're also, making note of descriptive summaries and any thoughts, feelings, and patterns that present themselves in the research. So this is what we found. I know it looks super, super complicated, but I'm going to break it down for you. These are the pathways to healthcare. And so typically what happens is youth undergoes intake at shelter, where they may experience a health concern. And then depending on whether that health concern is a crisis or not, one of two things can happen. So if it is not a healthcare crisis, and the youth shelter does have health services integrated on site, then chances are that youth may receive timely care. This could be through a shelter clinic if the youth shelter has that on site, such as Covenant House in Toronto. If the Inner City Health Associates are providing services on site at the time that the youth needs them, or if the youth shelter has employed independent practitioners to provide primary health care services on site, whether that's, primary care, mental health care, addictions care, whatever it is. And there are various shelters who have these independent practitioners on site. However, if these health services are not integrated on site, then the caseworker or frontline worker or whoever is on site will typically refer the young person to primary care externally. So this could be a walk-in clinic, which is close by. It could be community agencies that are either close by or that they have partnered with. Or they may simply just say, you know what, maybe you should go to the hospital, and they would go to the emergency department. If it is a crisis situation, so I'll go down this complicated diagram. So if it is a crisis situation, then typically what happens, and I'm sure many of you have seen this where you work, but typically what happens is there would be EMS or police response to the hospital where young people would be taken either to the emergency department or they would be admitted to inpatient care. And this is where the disconnect is. Oftentimes, youth are prematurely discharged from hospitals and they follow this red loop here, which I term the endless shelter hospital loop. And some causes for this premature discharge is that youth often experience stigma and discrimination within the health system. A lot of the time they're escorted out by security before they can even receive care for their health needs. And then a lot of the time mental health concerns are dismissed and they just end up following the loop, seeking care for unresolved health challenges. So what does this tell us? It reaffirms that there's insufficient engagement within and between these sectors. It's very, very fragmented. We saw that there were multiple routes to the endless shelter hospital loop. And what we found was youth who have more complex needs or higher risk youth who are residing within emergency youth shelters who have less capacity, so they may not have integrated health services on site. They are more likely to take the shortest route to the endless loop, which I described earlier. So now I'd like to ask you, what are some ways, based on your own experiences, but also what I just shared, what are some ways in which healthcare coordination can be improved within and between the emergency youth shelter and health systems for youth experiencing homelessness? Any thoughts? Did I see a hand?
Taking time to listen to them.
Taking time to listen to them.
Meeting them where they're at, that's very crucial.
Yeah, absolutely. That's a big one.
And leave your judgments behind.
Yeah.
More staff to accompany, because oftentimes youth have to go on their own because there's not enough staff on the ground. So they end up, especially if they're dealing with mental health issues, they end up in front of questions they don't know how to answer. Et cetera, et cetera.
Yeah, that's also
support.
Yeah. So perhaps
The fourth person has to be trusting too.
accompaniment by a trusted adult. Absolutely.
Yeah.
Absolutely. I saw a few other hands.
Leveraging community health services and nurse practitioners, physicians, other allied health professionals to provide some low barrier access to healthcare on site, which would bridge that trust to go somewhere if they needed it. But that would be, they're already doing that work in community health centers and family health teams, and just having them provide their work in a different setting.
Absolutely. Yep. So bridging those connections.
But
Perhaps.
not everybody has a community health center, so you have to look at that framework.
Community health center, family physicians, nurse practitioners, registered nurses. It's looking at where you can leverage those services from, because they're doing that work, they're getting funded for that work. They can just do it in a different setting.
Absolutely, and yes, I think that would differ from region to region, city to town, but absolutely. Yeah.
I think there being like a system where there can actually be like, let's say a client is intake to a shelter where there's a signed consent, so should the client end up in a hospital, the shelter can actually call to check in to get information, because often that is also a gap where, you know, we send a client to the hospital and then we're calling to follow up and they can disclose no information, right?
Yeah.
So I think having a system like that will also be.
Yeah, and I think that leads right to policy change, because these information sharing and privacy policies are the barriers getting in the way of that communication between and within circles of care. Yeah.
You know, we appropriately mentioned transitionally aged youth.
Mm-hmm.
So instead of having to leverage child and youth mental health and healthcare systems, and then also the adult sector, because someone turned 18, that is a transition and a drop-off point where a lot of issues occur, because there's not a recognition of the special needs that are existent within that age bracket that we all work in.
Yeah, absolutely.
The health system is nobody is there.
And I think there's also not as much awareness as well about what community resources focus on the youth population as opposed to the general public. Yeah.
Earlier you had mentioned about it being between the client and the physician. I think maybe providing youth with their rights and informing them, letting them know what their rights are, so they're able to actually advocate for themselves if they are put in that situation, in case that support and that help isn't there.
Absolutely. Yeah. Thank you. Yeah.
I think we tend to avoid the need for an overhaul of our emergency health care system. Like our ER, our emergency rooms, our psych emergency rooms, you can wrap them up a little bit differently, but they're still delivering the same service that they have institutionally for years, and it has created a second-tier system where we have a shelter health network where we're delivering healthcare services, where our institutions need to actually embrace change and start delivering patient care. I'm not faulting nurses. I am taking a direct stab at our healthcare institution. We need to change.
Yeah. I agree.
Earlier on you mentioned about kind of premature discharge of the system. It's better if the relationship kind of treatment is adopted, like the first presenter said, when relating with this group in the clinical setting, rather than just being professional and clinical. There's really no connection between the physician and this youth because of the case, you know, at hand. So if they can adopt a kind of relationship form of treatment, you know, that would be more impactful to this youth rather than discharging them prematurely.
Absolutely, and I think relationship building is very, very important and impactful at any level of these or any place in these trajectories to care, definitely. And I think I saw a hand. Yeah.
A continuation of the first one, youth harm reduction. For a lot of folks who are entrenched in substance use, overdose prevention sites are primary health care providers, but there's lack of youth-focused overdose prevention sites.
Yeah, yeah, and I've heard that time and time again, even in Toronto. Yeah, and I think I saw a hand here.
This might be different from community to community, but in Hamilton, Ontario, we have figured out a little bit of a way of communicating with the emergency department. The shelters and the hospitals have a common form that we use that is called a hospital to shelter transfer form, and that allows for consent to be signed ahead of time, so that regardless of us having 24/7 sites, if we are sending somebody to the emergency department, we send that form and that access consent, then we can call back and check in. We can ask for discharge summaries. The connection with the emergency department is not necessarily as fluid as we want it to be, but at least we have an existing practice. And if we get somebody on the phone that says, well, we don't have consent, go back to your fax machine, the form is there. It has mitigated some of the coordination aspects.
That's, yeah, having those consistent processes between sectors goes a long way. And I'll take one last one over here.
It's not really, it's more of a question actually, what you just mentioned, is the form of physical form that they have to go with. Just with the earlier conversation, talking about how people communicate and it being a form and that it can be lost, maybe it's being innovative and thinking of QR codes or something that can stay forward to the population.
That's a great.
Youth signs ahead of time when they first come in, when they're not in crisis, knowing that, and so when they come back, you have to redo them. But you have one existing that goes to the
Yeah, thank you. Thank you. Those were all really great points. And I'll share some of what came up in my research. So these are some variables, and many of you have mentioned many of them already, but these are some variables that do influence youth's trajectories to care. So the first is relationships early on. So if frontline staff or any staff are able to build those relationships, those positive, trusting relationships with youth early on, youth are more likely to communicate their health needs earlier on and are less likely to follow the crises, routes to healthcare. The second one is health services integration, and I was attending a presentation that discussed this earlier, but having those health services integrated on site minimizes that barrier of having to travel outside the shelter to receive that care, and also prevents youth from having to enter a system that may have been triggering in the past or to which they may not have the best relationship. Another one is knowledge of community resources, like someone had mentioned earlier, but if frontline staff are aware, and I know Toronto is complex and there's so many resources out there, but if frontline staff are aware of community resources that are out there, they can more appropriately and adequately refer youth, if they don't have health services integrated on site, to resources that will best meet their needs. So youth-specific resources and resources that address their specific health concern, as opposed to saying, here, go to the hospital. And then information sharing policies, like someone else mentioned. These act as a huge barrier in communicating between and within sectors. And a lot of this critical health information actually plays a role in changing the trajectory of care, or the pathway to care that the youth follows, because just critical information that the youth may not have been able to share, if that was already passed on, it could change the trajectory of what the discharge plan looks like, and vice versa. So that's another one. And then structuring safety for youth. This is also another important one, but it refers to creating a more welcoming environment, a non-stigmatizing and non-discriminating environment within the health system and the shelter system, and therefore youth again would be able to be more open with the workers and be more willing to access the services that they need. Now, this is another complicated diagram. I'm not going to get into it. But this one is just showing how all the different parts are connected. So very briefly, you see healthcare coordination and the endless loop central to the diagram. In this turquoise box, this is systems thinking, guys. In this turquoise box, that's more focused on the health system side, but targeting variables such as the staff response when youth first, enter the health system or the hospital, the response that they get from staff, how accessible the health system is. For instance, a stakeholder I was speaking to mentioned, having that enhanced privacy during registration or during intake, so that youth are able to really talk about, their status with housing or any other information that, that may be difficult to communicate in a public space. And then within the emergency youth shelter system side, which is this side, there are other variables that can be targeted. And I think a big one is funding, but also having that human resource capacity, more frontline staff, those staff-youth relationships from the get-go, to improve youth staff communication. All of these variables would also influence whether they are moving towards having healthcare coordinated or moving towards the endless loop. And then finally, this last box here are variables or inputs that would improve or strengthen healthcare coordination within and between systems. So they're not specific to shelter or health system, but establishing those strategic partnerships, those formal referral pathways, collaboratively managing collaborative case management and discharge planning, facilitating those warm transfers. So like someone said earlier, like, you know, having a trusted frontline worker or, you know, outreach worker, healthcare provider actually physically take a young person to their next point of care, as opposed to just saying, here's a piece of paper, these are some resources, these might be helpful. And finally, these are some levers that were identified to strengthen healthcare coordination. So in basic terms, these are recommendations, and they're more specific. But the first one is clarifying staff accountability by adapting staff roles that have formal responsibility for healthcare coordination, adjusting policies such as discharge policies, information sharing policies, privacy policies, prioritizing and dispersing funds more intentionally. So, you know, there's all this research happening. There are programs and initiatives and evaluations of programs that are shown to work, that are shown to be cost effective. So perhaps funds should be more intentionally prioritized in those areas. And then incorporating systems crossover, and I think this is a big one. So this could include the physical crossover within or between systems. So like I mentioned earlier, warm transfers. I remember speaking to a healthcare provider, a social worker, and she was like, I just wish I could leave the hospital with this youth and like take them to where they need to go next. Like being able to leave institutional walls, which is often, you know, not easy to do when you're in a healthcare or shelter setting, more so in the healthcare setting. And also having interdisciplinary teams working out of one location, which we see sometimes in the shelter space when they have integrated health services on site. The fifth one here is enhancing systems accessibility, so providing consistent and low barrier care offered at times when you know youth might need to access them, enhancing that privacy in public spaces, and then formalizing some of those strategic relationships between sectors. And then integrating social medicine, so this is more about considering and incorporating the social determinants of health and approaches to healthcare. So not just approaching healthcare as, you know, clinical. There's many more facets to healthcare socially that need to be considered in approaches to care. And then streamlining health communication and information sharing through centralized channels. There is just so much information and so many resources out there, but the problem is people don't always know what exists out there, especially in Toronto. So streamlining that through centralized channels. And then finally, really defining what healthcare coordination processes look like. So from organization to organization, sector to sector, this looks quite different, and everyone seems to have their own process internally, but how can we make this more consistent across the system? So those are some levers for facilitating change. And in conclusion, we know that we need a more integrated systems response. We need to collaborate more. We need to be on the same page, I think, not only in terms of our processes, but in terms of our values, our norms, and our attitudes towards caring, healthcare coordination, and care. And I recommend that stakeholders within either of these sectors consider these levers for change that I mentioned, and as well as some of what I mentioned here, in efforts to strengthen healthcare coordination. Thank you.
Thank you for that. I think my big takeaway from that presentation is how harmful our siloed approach to things can be. So I'm just going to move this over for a second. So I have 3 presenters for the next one, so bear with me. I have a lot to say about them. So I'm going to introduce, so this next presentation is Youth Substance Use Program Provides Dignity to Young People Who Use Substances. So I'll introduce Caitlin from Good Shepherd Notre Dame House. Caitlin. She's a child and youth care practitioner who has worked at Good Shepherd Notre Dame House since she completed her student placement there nearly 6 years ago, moving quickly from student to part-time youth support worker, then full-time youth support worker to team lead, before landing as program manager in November of 2022. In this role, Caitlin wears many hats as she manages the residential shelter program, the community resource center run out of the shelter diversion and landlord liaison programs, and the youth substance use program. Caitlin is a lifelong learner who, along with her diploma in child and youth care, holds a diploma in small business and entrepreneurship, and is currently completing a bachelor's degree in psychology from Laurentian University. I also introduced Norma from Good Shepherd Youth Services. Since 2008, Norma has served as program manager for many of the Good Shepherd Youth Services programs in Hamilton, including the Regina's Place program for young parents, the Brennan House Treatment Facility for youth experiencing mental health challenges, and the Notre Dame House Emergency Youth Shelter. In 2009, she took on the role of program director and continues to strive to lead the youth services teams to help youth hope, dream, and achieve. She has already seen a lot of change in the agency in serving youth, training staff, and opening and closing programs, and she intends to stay until retirement because she loves her job. Yeah. And Carrie is from St. Joseph Healthcare Hamilton. She has 23 years in addiction treatment, program development, training in community collaboration, and providing addiction support and programming. And I thought this was too short as a bio, and so I asked her if there's anything else interesting about herself. And this month she is traveling coast to coast to Halifax for this conference, and then to Vancouver for Issues of Substance in a few weeks. So, and she loves to travel.
Great. Thank you so much, everybody. I'm really excited to see so many folks here who are interested in talking about youth substance use. I think as some of our other presenters have mentioned, like, it's such an important topic to keep at the forefront of conversations, because the reality is more and more youth are using substances every day. And so we're just going to talk a little bit about our program that we have in shelter. So the goals that we're hoping to get through this presentation is we're hoping that you'll gain an understanding of how we received the funding to create our program, kind of how the program functions on a day-to-day basis, and then how dignity is increased for our youth who are using substances in shelter. So what is YSUP? So that's our acronym for it that we commonly refer to. It's the Youth Substance Use Program. It's a unique in-shelter intoxication and withdrawal management program with a partnership between the 2 agencies that we just spoke of. There are withdrawal management, non-medical withdrawal management services provided through St. Joe's, and the program is housed out of Notre Dame House through Good Shepherd program. Just a little bit about Notre Dame House, where the program is housed. We are the only youth shelter in Hamilton, Ontario. We serve youth 16 to 21 with 21 beds and an additional 5 beds for our YSUP program. Just some numbers for the shelter. In 2021, we saw around 2,734 overnight stays, and then an 80% increase in that into 2022. And our projections for 2023 are going to be probably over 5,500 overnight stays, because we're averaging about 420 nights per month, give or take 50 on a month, given whatever circumstances. So our overnight stays are increasing. Our use of the substance use program is increasing as well. I'm going to hand it over to Norma.
Okay. So, can we change? I'm going to spend a little bit of time explaining how it started. I think it's really important. We had people here talking about research and work being done towards developing programs for youth. And so back in 2005, there was an assessment done in Hamilton called Addressing the Needs of Street Involved and Homeless Youth. and there was 27 different recommendations. But 2 of those recommendations were specifically geared towards street involved and homeless youth who were using substances. The assessment looked at service providers, also talked to youth, and one of the things that was identified was that there was a need for advocating for services that were dedicated to youth, that provided best practices. The second recommendation was that the youth did not want to go to the hospital to detox. They wanted a safe place to detox. But what were we doing as the shelter? If a youth came under the influence, we would send them to the hospital. We would tell them that it was not safe for us to keep them in shelter. I think that there was this concept of worry that we don't want you to go to bed and we don't know what happens. What we were creating was a barrier. Maybe it felt good for us. I don't know what we were afraid of, but at that time, we were basically infusing a group of individuals being sent to the emergency department. We were not getting information back on what was done. We were not getting any recommendations on next steps. And the youth that knew that that was the process would say, screw you guys, I'm not going. And in turn, they would be putting themselves at risk sometimes, staying in inappropriate places or staying in places that were not safe, using more. What we were seeing is that we were losing leverage in case management and support. So any opportunities to enhance whatever work had happened at the shelter level was lost. We couldn't do any referrals to the in-service in-house, no mental health, no warm transfers, no substance use support. Nothing of that could be done. So the call for proposals came from the Ministry of Health. 2005 was when the study was done. 2012 was when the call came. We saved those papers. We knew it was there. We said, well, let's do it. Caitlin, can you go to the next slide? So we looked at a unique approach that would be youth-friendly, that would leverage the resources, the infrastructure, and the skills that we had to develop a program that offered an option of harm reduction for youth who were coming to the shelter. And that's when we knocked at the door at St. Joe's and said, want to join us? And they were gracious. Collaborations are hard if you work in this system. We all have different ideas. We always feel that we do the best, and other people don't know what they're doing. And so collaborating can be really hard, right? So we invited St. Joe's, and the partnership has been amazing, and we'll talk a little bit more about that.
Can I just add to that? I think, too, the important piece is that our withdrawal management, our adult withdrawal management centers are actually not based in the hospital. We are the hospital, but we're off-site from the hospital, so that created a better relationship and gave us a little bit more leeway to do things that way.
And we started with a shift that makes no sense, 9 p.m. to 2 a.m. But that was what the money allowed, right? So 156,000, let's do it. So, and very quickly we realized that we needed more. We are not where we want to be, but within a few months or a few years, right? We were able to advocate for an expansion of the hours. So as it stands right now, at 241,000 budget, this is not a lot. The program pays for itself. If you count the ambulance ride, the 2 paramedics, the doctor, the nurse, everything that goes into the hospital, this money is, I call it peanuts. It's peanuts added to it. So it's a great investment and has been replicated in some other adult services. And I highly recommend, and we'll talk more about the gains and all of that stuff. But it is a concept that eliminates barriers for individuals who are using substances and are coming to shelter.
So I'm going to talk a little bit about how the program increases dignity for substance-using youth. Obviously, the first part of that is that they're not getting sent to the hospital. That was a huge barrier. Obviously, youth didn't want to do it. So one of the biggest parts is that we're meeting the youth where they're at. And I know that's a phrase that gets thrown around a lot in youth work. But what that really means for us is that it starts with building trust and it starts with building relationships. We have to know the youth in order to support them in the best way possible. So, we start with building trust. We look at harm reduction. We look at how we can prepare a youth for treatment when they're ready for it. So we don't push treatment in any way, but when they're ready for it, we have the whole team is ready to jump and do the steps necessary to get them there. It's a huge decrease in stigma. Obviously, sending them to the hospital created a lot of stigma. It felt like a punishment. It was a barrier to accessing. It felt like we didn't want them there because they were using. Now, one of the things that is the biggest thing is that it's a proactive approach rather than reactive. When they return under the influence, we have a plan in place on how to support them. And that plan is discussed with every youth at intake. So at the bottom there, you'll see every youth is assessed. Every youth gets treated the exact same way, and at intake to the shelter, this program is explained to every single youth. So there's no surprises when they come back under the influence, and we're like, okay, you're gonna access the YSEP program. They know what that means. They know that it's about support and it's about a genuine concern. Go back. We also apply trauma-informed practices, obviously, another big thing in the youth sector. And I think that really comes from, again, a lot of the parents, as our other panelists talked about, there's a lot of trauma in using substances because their parents have put so much stigma and shame around that. So one of the things that we're really applying is this idea that there is no judgment around substance use. You come as you are and we help support you, that's it. A big piece also is education to youth and to staff around harm reduction philosophies and principles. A lot of our staff, despite their numerous educations, come in not knowing what this actually looks like, or they're afraid to talk about it in a youth context. So part of what we do is put a huge emphasis on education and where our staff can get that extra support in knowing the right way to talk to youth, the right way to support them. And then being supportive versus authoritative, that kind of goes back into, we're not trying to be paternalistic. We're not saying we know what's best for them. Often the support just looks like them coming to the door at 3 in the morning and checking in, and we say, are you ready to go to sleep yet? No, but I'm kind of cold. So we give them things to wear. We give them all the pocket warmers, everything, whatever they need. Sometimes it's a naloxone kit. It can be all kinds of different things. So it's just coming for whatever they need. Just a quick note on eligibility. Obviously, you have to be within our age range for our shelter. Usually, our clients are staying in shelter, but there is the opportunity for youth who are not necessarily staying in shelter to access the program as well if they're kind of inadequately housed or homeless but sleeping rough. It is voluntary, so this gets a little bit tricky because we still have to rely on policy, but usually what happens if somebody doesn't want to be on program is that we'll sit with them for a little while until they're not as under the influence. We'll look at what that looks like, the risk to them, the risk to us. We'll sit with them for a while, and then usually after a little bit, we can say, okay, you're probably good to go to your regular room, no problem, and then we'll just check on them a few times throughout the night to make sure they are actually okay. Being able to walk, being ambulatory, so if you're falling down, if you're vomiting, these are things that can be indicative of a more intense medical emergency. So that's the kind of thing that we're looking for. And then you have to not be a risk to yourself or others, exhibiting kind of nonviolent behavior. Not to say that we don't get a lot of aggressive behavior, but our staff are well trained in kind of where is that line between aggression and actual risk and threat. So we're ready to take the verbal lashings. We know what that's all about, but we do have to have a sort of a very hard line when it comes to physical violence. So
which is rare.
It is rare, yes.
We find that youth are more self-destructive than they are to staff. And so I always like to dismiss the fear that, oh, people are violent. They're not violent.
Yeah, we've had very few incidents of violence. And in fact, most of the violence we see in the shelter is not related to the youth who are on the program. And then the last piece is that they have to be willing to manage withdrawal without addictions medicine. If that is something that they're seeking, then we would have to refer them to another program. Unfortunately, we're just not there yet. Our YSEP team is made up of, it goes from 9 p.m. to noon now, 7 days a week, 365. There's no day that we go without YSEP unless we have a sick call, and sometimes we have to manage without. But we have one withdrawal management worker on site. They're there from 9 p.m. until 9 a.m. We have Good Shepherd YSEP workers who are 2 shifts, 9 p.m. to 4:30 a.m., and a second shift from 4:30 until noon. So there's a little bit longer shift for that YSEP worker so that they can stay until noon and kind of support with the follow-up and aftercare and kind of, help them get ready for the day, make referrals if needed, kind of just support them with, getting through the morning after. And then there's always a mental health clinician available for follow-up support if they're interested. Some of our additional in-house supports, which has been a really beneficial thing for our youth, is we have an addictions counselor from a Hamilton organization called Alternatives for Youth. We have physicians from our shelter health network that are in shelter, and we have a clinic set up in the shelter so they're able to access a doctor if they need it. We have public health nurses who come for clinics to test for infectious diseases. They can do wound treatment, all kinds of different things. And then we recently added a rapid access addictions medicine, or RAM, nurse practitioner through the larger Good Shepherd organization. So they're mobile and they have the ability to come to us when our youth need them. So how does it work? It starts with information sharing. So our shelter workers are on the floor with the youth all day building relationships, and the youth will often disclose substance use. They'll come back, sometimes we can tell just by their presentation, but oftentimes they'll talk to us about it as well. We have that relationship, so they'll tell us, I did this today, or some youth will say, I need YSEP tonight, this is what I did, right? We also look at suspected or disclosed substance use or withdrawal through the day. So if we're observing, like I said, out of character behaviors or unusual presentations. Medication is a huge issue, right? There are lots of interactions with psychotropic medications. And so that communication between our frontline staff and the withdrawal management specialist is really about, how can we maximize the ability of them to take their medications while remaining safe in terms of interactions with substances. And then from 9 p.m. onward, anyone who comes to the front door or accesses the dorms is assessed for substance use. So all of that is shared during our shift change. It starts with that information sharing from the frontline workers who've been there all day to the withdrawal management specialists. I hand it over to Carrie now.
Good afternoon. So I'm going to talk a little bit more about what goes into the assessment phase when they come through the front door, some considerations, and keep in mind we're a withdrawal management center that serves adults, and so typically when we first started back in 2015, we had this very clinical profile asking question after question. The youth told us very quickly they're not interested in giving that information, right? So had to really train my staff to think differently and not to rely on getting the information, but really building the relationships and learning about the staff. So that was probably the biggest lesson learned over the years, that we do not do. It's not about getting a detailed, comprehensive assessment. That when you're in a withdrawal management center, you're kind of gathering all that information. So we rely on them being educated on the signs and symptoms, and so really being able to identify, look at the identification and management of intoxication and withdrawal, and knowing, is there emergency actually attached to that state? And that would be the last resort, right? Knowing that, can we manage them where they are, right, where with the support of our staff and the YSUP staff and the other youth workers as well. It's very much a team approach. And so I think some of the keys is not only the self-disclosure. I think the key is rather really becoming familiar with the youth rather than even the individual symptoms that you're presenting. And so those conversations, having those open, very casual conversations as they're coming through the door with every single youth, whether they're using or not, is what has made this program successful today. And where we get the youth coming and asking now to be put on YSUP programs. So that's the key. And I think the other learning piece around the assessment is we had to change our language from risk and not say, oh, you know, this is risky behavior. Yeah, that's what I'm about, right? I'm all about taking risk. And so it's about coming from and having conversations around genuine concern. We're concerned for you, and not so much talking about the actual risk, right? And so that environment's important, that you portray that, and that you become sensitive and working as a team. And so just really, I think the important message is about taking those opportunities to build the consistent, positive, trusting relationship and consistency amongst the team team members. We used to have staff trade off, go like one staff from and rotate them through, and now I pretty well try to keep it that I have 2 full-time people there and consistent to help with that consistency on the relationships. The triage and assessment piece, so this is basically their work to do at the beginning after they identify that someone is under the influence, and what is the next care plan and the decision tree on that. So the very last, what's the word I'm looking for? Option or resort, I guess, is the hospital, right? We know youth do not want to go to the hospital. However, we communicate right up front that when the severity of need is evident, it's evident that this is the option we need to make. Very rare that we send, and you'll see numbers, our numbers that have gone to the hospital. That's one of the pathways. The second pathway is where they would be referred to our men's addiction service, which is known as MASH in Hamilton, or the Womankind Addiction Service. So those are our adult withdrawal management centers off-site. And typically the youth are a little more resistant to go that route. And we would only offer and have that conversation if they're needing additional support, and that's usually where the buy-in is. So youth are actually coming in probably more under the influence and intoxicated versus withdrawal. By the time my program ends, they're entering withdrawal, and so then they have to get up. So that's our kind of window of opportunity to have conversations about, would you like to do a warm transfer over to the adult Womankind or MASH and be able to have just the day, a few hours, sleep a little bit longer, get the support there, and overnight. And so we've been successful in those cases as well. They don't take that opportunity as much, and actually we're more proud to say that we actually serve them right where they at. So most nights we can have the youth there. So that's the YSUP. So it's a youth-friendly space. They're placed in the observation room, and they're provided supportive care. So we'll have conversations, give them information if they're first-time users, they don't know what to expect, or even if they have used before, we'll provide that education. We give comfort aids, we provide fluids, etc. So it's all the supportive care wraparound services. That's it.
So as we mentioned before, this started as a 9 p.m. to 2 a.m. program. So we very quickly learned that that wasn't enough. And some of the kind of learning and gains with the extended hours of operation means that we can kind of give them a continued assessment throughout the night. So, you know, at 2 a.m. before, it was kind of passed off as the duties to the regular shelter staff. And as you can imagine, they're quite busy, and sometimes that would get kind of left on the side of their desk, right? And so now there's a consistent assessment and monitoring throughout the night, right up until 9 a.m. So it's every 15 to 30 minutes, kind of depending on how the youth is presenting and what substances they may have used. In addition to the shift change that happens in the evening, we have added a shift change in the morning. So now they're kind of passing on all of the information of what happened through the night, because oftentimes youth are not just coming in under the influence and getting in their bed and going to sleep. Oftentimes they're using, you know, amphetamines or substances that don't really allow them to sleep well. So oftentimes, again, it's just sitting with youth. You know, we sometimes will play cards with them. We give them coloring books, kind of whatever they need to get through the night. We have, you know, LED lights that can kind of change the ambiance of the room if they need a lower light, right? So just kind of giving them that comfort. And so they'll, in the AM shift change, they'll kind of explain how their night went and what kind of supports they might recommend throughout the day as the youth transitions into the daytime. It's also allowed us to add bed rest for those who need it. So unfortunately, our kids have to get up in the shelter at 7:30 a.m. And so if you can imagine, if you've been using substances all night, that can be a pretty harsh time of day to wake up. So having that extended program hours has allowed us to give bed rest to those youth who may have been up all night and have just fallen asleep at 7:30 when everyone else is starting to wake up. We talked about continued support as the client transitions, and ability to identify patterns of use, and then knowledge exchange. So these are all things that we've kind of gained through that extended time. Yes, back to Norma.
Absolutely. So what we have seen is really enhancement of skills for our staff, less fear about managing and supporting individuals who are using substances. Youth come to us, they come to the door and they ask for support. They know we have naloxone kits. Their friends are not doing well in the community. They'll come and knock on the door and say, can I have a naloxone kit? So that has been amazing. I was telling everybody we keep track of nightly news, and so we know how many people slept, what happened, what didn't happen. I've been a Good Shepherd for many, many years, almost 20, and it used to be so hard to work night shift because staff didn't have the skills, didn't have the understanding, struggled with ratios. We have 4 people working, and so do you sleep? And for those who are using substances and can't sleep, they're being supported. So that is tremendous in the sense that I'm not having new staff tell each other, you're gonna go and work night shift at the shelter? Ooh. So, you know, it really goes a long way if people feel equipped to manage what comes to the doors. And I was telling everybody about a situation where we had a youth that was withdrawing, and she was not doing so well, but not doing bad. So was just laying down there, and I saw a staff member come in at the beginning of his shift as we were about to serve dinner, and he acknowledged the youth. I didn't coach him. I didn't say anything. He said, hey, how you doing? How you feeling? Do you think you're gonna be able to eat some dinner? And she said, I'm not feeling that well. He said, well, do you want anything to drink? And she said, yeah, maybe. The level of care and the humanity that is added to that piece, because that kid is not being ignored. That kid is being told, I see you, what do you need? Is something that we have gained as a team to be able to manage what comes to our door. The partnerships have been amazing. I have Carrie's cell phone number. She has my number. Something is going on, we text each other. It goes a long way. And so that has been what we have seen. So next, go ahead. we also have seen an increase of overdoses, not necessarily in the building. Unfortunately, it's happening across the street. And if we didn't have the capacity that we have with the YSAP program, I bet that our staff would not run and rush across the street to administer naloxone. The knowledge that they have, the skill that they have, allows them to be confident in crossing that street. If they didn't have that knowledge and that exposure, probably would just be a 911 call with no naloxone being administered. We have had 2 overdoses on site. And this is for July to August, we had 13, which is pretty high, across the street. Not individuals that are staying within the shelter, and then 2 of them on site.
Right? Okay. And all of those youth were successfully given naloxone and all made it to the hospital and recovered. So I just wanted to point out some youth comments from one of our feedback surveys. So one person saying, "The Dame is the best. I'm thankful for the dedicated staff's hard work and continued dedication to supporting me and helping me make positive change. When I came back after taking a weed edible, and I think it was laced with something, the staff helped me a lot and I felt safe. And the last one, I was extremely well taken care of when I was drunk." So we're really happy to get feedback like that. It really shows what we were doing is effective. Just a few numbers for those who like the numbers. So just some data from 2021, 2022, and up until September of 2023. You can see that we have successfully diverted over 5,000 youth from accessing the ER since opening in 2015. And then since that, it's been 8 years, we've only sent 102 people to the hospital, which is an extremely low number compared to what we were sending before. Hopes for growth. Do you want to jump back up? Or? Sure. Okay.
We would love to have a 24/7 YSAP program, but we need money, and we can't. The building that we have has completely outgrown what we do. So whenever the next iteration of funding comes from whatever ministry, we will apply for 24/7. Obviously, we need a new building. We keep adding and investing. It's just ridiculous. We paid $16,000 for a shower that I don't believe is that price, but it's what works.
I think it's important that you know that the withdrawal program is actually, you have to walk up several stairs.
It's a steep thing of stairs like that. Yeah, we need a new building. Of course, we also have identified that we need an on-site harm reduction worker, and that would allow us to expand our harm reduction services. Because what we find is that the need for the youth doesn't stop at 12 p.m. when our worker goes home. And so we are running a shelter, we are running a community resource center, and we are trying to support individuals who are withdrawing from substances. It just doesn't work. We try our best. And we are also looking at expanding harm reduction policies. Good Shepherd has some new initiatives coming, including a health bus that will be distributing some gear, which is not what we provide within the YSAP, but youth do have access to it if they go to other service providers. Oh, out of time? Okay, thank you.
I'll just throw up, last slide is just contact information. If anyone wants to reach out to discuss the program more, please feel free.
Thank you so much. I'm really reluctant to cut people off because I'm really impressed by this work. The older I get, the younger you seem. And the fact that we just decide that kids that suddenly have to take care of themselves all of a sudden at 18 and then much younger when those kids are white. We need to really be taking care of people. I still need support. I'm 40. Let's do better. Questions?
So it was mentioned at the start that there's maybe a reluctance or a challenge to explore youth harm reduction. And so I wonder, Yeah, what are some barriers that y'all face, but also what advocacy is being done and how can you join that?
I mean, can you hear me? Yeah. I think there are a lot of barriers, but we as like service providers need to be brave despite those barriers. Our youth deserve it. All I do is advocate. You can tell like this is my passion project, and I think if more people spend time exploring like what harm reduction is, they will also become passionate. Someone very wise once told me that just because it's uncomfortable doesn't mean it's unsafe. And I think that is something that is like really powerful to remember in your youth work practice. That just because people are uncomfortable talking about it doesn't mean it doesn't happen, and doesn't mean that it's inherently unsafe. And so I think just like being brave in the face of people who poo-poo what we say will take us a long way.
And I think just to add to that, what we can continue to do is, you know, do the research, collect the data, tell the story through numbers, because they don't lie, and it's and you know the work that we're doing is empirically founded. You know, there is research, it is fact. It's not us hokey West Coasters on Vancouver Island trying something, you know, totally out of the box. It works. It is saving lives, and yeah. So I think continue to support the research and the advocacy, and yeah.
I also think about making sure that for those who serve youth, that you are at tables where discussions are happening about harm reduction, about supports, about funding, because I find that it tends to be adult. It's about the adult population and not specific to youth. And youth do need different approaches, yes, but youth need to be considered because they're youth and they're our future. So a lot of times making sure that if you can, and I know we have lots going on, make sure that you are at those tables where decisions are being made or funding is being dispersed, and put your hand up and say, what about youth, right? So.
So my question is specifically for Casey and Angela, but thank you all of you for your passion and for the work that you do with youth and who use substances. A little context, I'm a researcher. I look at harm reduction and housing first for youth. And a little background for my question is that we are working with a program in Kelowna, Housing First for Youth program, and an issue that they're having is finding youth-specific housing for youth who are actively using substances. So you've got supportive housing, who is recovery-oriented but requires that period of abstinence or stability, and doesn't let youth use substances on site. And then you have market rentals that lack that support that supportive housing buildings obviously have, and landlords who don't want youth who use drugs. And so my question for you is, how do you navigate that situation when you have a youth who's actively using substances, who's maybe not ready to enter that period of stability that you may require at the beginning of your program? How do you kind of navigate that so you're not leaving youth unhoused, which is kind of what we're seeing?
Totally. So we're really fortunate that we have a housing continuum model at Threshold, so that we genuinely, you know, we have housing that we operate, we are responsible for, where substance use can be supported and managed. We also are really bold and brave and act as the renter in community with landlords, so that we are the renter. We take responsibility for what happens within the units that we are renting, and we support with heavy intensive case management the youth that are living there to use substances in a way that isn't problematic for the whole community. We recognize and acknowledge that being a good neighbor is something that you need to be in community housing settings, private market settings. And so we attach intensive case managers to them to help support them in gaining the skills that they need to be good neighbors maybe while still using substance use, because like good people, stable people use substances, you know? And so, yeah, so we're very fortunate that we have that continuum of housing where we can support kiddos from recovery to our more hands-off but still lightly supported housing to fully independent housing with that case management support. So that's how we've managed to address it, is like, we'll just do it ourselves, right? It's like, if they won't build it, we'll figure it out and we'll just do it ourselves and create the model and the supports that we know our community needs. Thank you.
More questions?
I just had a question for YSEP. In terms of the withdrawal management workers or your staff and team, is that, like, what's the full scope of that role? Is that something like a medical designation, or how does that, is that just more of like a peer level? Like,
they could have some lived experience, so all my staff, but they're unregulated. They're addiction workers, community service workers, social work background.
Or that support for their lives versus like the addressing any kind of, so as soon as there's a medical complications, that's when you guys are looking at your kind of
then we
escalation path.
Yeah, they could actually go into our withdrawal management, because although we're non-medical, we have medical supports on site, so that could be a route versus going directly to the hospital. But if it's an actual medical emergency and it's evident, then we would refer the hospital. We'd have those conversations, which is another good piece, is that we would have that warm transfer and call the emergency, and we have addiction workers in the emergency department now in RAM that we could connect to.
Yeah. So just thinking of dehydration or something like that, that's outside the scope of the support approval.
Not necessarily. Depends
well,
on
sorry,
if it deviates, it doesn't get better. Yeah.
The medical complication.
Yeah.
Thank you.
Any more?
It's not a really baked question yet, but speaking to the reluctance around substance use with young people in harm reduction, have your programs been tested in the ways that more risk-averse organizations may not be getting to this space yet, around political, public opinion, legal tests that if you were trying to convince a board or a funding body that this is the right thing to do? Do you have examples of what you've had to wade through or myths that you could dispel that may be helpful for people in the audience who might be looking to walk down this path? So what stumbling blocks have you encountered or actually not encountered that aren't actually really, things to be afraid of?
I think that we can all be, like, there are so many, like, barriers to what we do in our program and what a lot of us are doing, it sounds like. But in the 3 years that we've had our program, like, we haven't had, like, police will bring kids home sometimes and I'm straight up, this is what I'm doing. And they go, that's great. I think we're really lucky with our board, who move, like, boldly and bravely like we do. But I think when you believe in something so passionately, I just won't accept no as an answer, which doesn't always go over well. But I do think that when we are having these conversations and our program is in, like, a highfalutin area in Victoria, $1 million homes, and our neighbors love us and they love our kids. And I think that having people that are all on board and, like, represent it well goes a long way.
I was going to say we make really delicious Kool-Aid.
And we'll drink it.
You drank it today. Yeah, so similar to what Casey said, I think we're fortunate that we have local municipal political will to do this work in a good way and in the right way and in the ways that have been proven effective. And so we're very fortunate to be able to blaze the trail, and I think our evidence is clear in that less youth are dying, more youth that are in the child welfare system that have come through our program are not experiencing homelessness, because we're supporting them through that transition, you know, through child welfare, maybe through recovery. If not recovery, then through our housing, and then into independence. Like we're showing that, and we can tell those stories and read those quotes. And so, you know, we still get side eyes. You know, youth using substances it is uncomfortable. We don't love it either. It's heavy in our hearts to watch kiddos live at risk and make decisions that we know could literally kill them. But the alternative is just not an option. And so I am comfortable looking anybody in the face, even our funders who support us amazingly, our health authority, know what we do, support what we do, champion the work that we're doing. And I just think it's because we're pretty convincing.
I think too, something that, like, there are things that do support the work, and if you look for it, you will find it. You know, last year we found that we can apply for an exemption through the BC government so that my staff can transport illegal substances in their car to get tested. There are things that do support our work. It is not widely advertised, but they exist, and so I think, like, we exist and we persist.
And again, the evidence doesn't lie.
Yeah.
The evidence doesn't lie.
Fantastic way to wrap up. Thank you all so much for your presentation and for the work that you do. And if no one else